Hi, Michelle Glass here. Welcome back to our fourth episode of our Chapter 20, Lecture 20 series. There is a little piece of information here coming out of Chapter 21, so you're going to want to refer to those pages in your textbook for additional information. Now, this is where things in our discussion does get a little bit complicated, so take your time, take good notes, do some reading and additional research, or bring those questions to me in class. Whatever you need to do to get this information. So cardiac output is basically talking about the amount of blood that is pumped by the heart each minute. So in order to calculate the cardiac output, you would look at your heart rate, how many beats per minute, and you would multiply that times your stroke volume, which we talked about as your EDV minus your ESV. EDV, remember, is the amount of blood that makes its way into the ventricle at the start, and ESV is the amount of blood that gets left over after ejection has occurred. So stroke volume is talking about, well, how much blood was ejected? So if you want to calculate how much blood you're pumping in a minute, you need to look at how many beats per minute, and then how much blood you're pumping out with each one of those beats. Now, there are going to be several factors that affect heart rate. So heart rate, again, beats per minute. Sometimes this is abbreviated BPM. This is, of course, controlled by the autonomic nervous system. We've already talked about the sympathetic increasing heart rate and the parasympathetic decreasing heart rate. So we already know that's the case. And we've already seen the hormones epinephrine and norepinephrine being part of the sympathetic response. So it's not surprising that these hormones are going to increase your heart rate. And also T3, remember that's a thyroxine hormone, so hormones from the thyroid, which we talked about as increasing metabolism of your cells. So epinephrine, norepinephrine, and T3 are all going to be important in increasing your heart rate, and they do this by depolarizing the SA node. So they're going to tell that pacemaker group of cells, the SA node, to depolarize faster. So if that SA node is setting the rhythm of the heart, if you depolarize that node faster, then all of the group of cells will follow. In addition, we see that epinephrine will increase the contractility of your cardiac muscle cells. So that means the force that is generated with those contractions. So not only does the epinephrine help to increase your heart rate by depolarizing SA node, but then it also has an effect on increasing the contractility of your cardiac muscle. So clearly we see involvement here from both nervous system and hormones. Then we have this other function called the Bainbridge reflex. And what this is showing us is that the more blood that returns to the heart, so if you increase your venous return, you're stretching the cells of your atria more because there's more blood in there. And that's going to cause an increased depolarization of your SA node. So the more blood that you get coming into the heart, the more the faster your heart rate will be, or the increase of your SA node depolarization. Now, this is important because if you're being physically active, then you're pumping more blood back to the heart, and also you have an increased need or demand for that blood. So it makes sense that if you're physically active, that you're increasing your heart rate, versus if you're just sitting around watching A&P videos, you are not moving the blood as quickly back to the heart, and you don't need as rapid of a heart rate. Okay, when we are talking about the autonomic nervous system controlling heart rate, we do see that there are what are described as cardiac centers located in the medulla oblongata. So these are going to be groups of cells that are coordinating these different events. So the sympathetic division is increasing the heart rate. So that group of cells that's controlling the sympathetic neurons or fibers would be called the cardioacceleratory center. So what we see happening with our sympathetic response is we're going to release, of course, the hormone norepinephrine. So it can be released either at the synapse as a neurotransmitter, or it can be released from the adrenal medullae as a hormone. We know that norepinephrine is primarily binding with beta receptors, and in this case, we're binding with beta 1 receptors. Remember, there were 3 types. When norepinephrine binds with beta-1 receptors on the cardiac muscle cells, it's going to open up sodium channels. So that's increasing depolarization. And it's going to open up calcium channels, so both sodium and calcium move into the cell. So our depolarization is happening faster, and we're slowing down our repolarization. So together, then, the movement of sodium and calcium ions into the cell will increase our heart rate. When we look at the opposite response, we're looking at the effect of the parasympathetic division. And so this group of cells in the medulla oblongata would be called the cardioinhibitory center because, of course, parasympathetic division is decreasing heart rate. We also already know that acetylcholine is the neurotransmitter of the parasympathetic division. So here what we see happening is acetylcholine is opening up potassium channels. So potassium is going to leave the cell. It's going to slow down the depolarization. It's going to extend the repolarization. And so it's going to slow down the heart rate. So if you have positive charge potassium leaving the cell, it's slowing the heart rate. We see that the parasympathetic actually dominates in our resting heart rate. So a normal, healthy adult resting heart rate is about 70 to 80 beats per minute, which is lower than the spontaneous rhythm set by the SA node. SA node can generate action potentials 80 to 100 beats per minute, so it's a much faster. So we see the parasympathetic at rest is overriding the activity of the SA node, slowing it down to the 70 to 80 beats per minute. Okay, next we need to talk about our stroke volume. So remember, stroke volume is also affecting cardiac output. Stroke volume is the total amount of blood being ejected, and we calculate this by looking at the EDV minus the ESV. Remember, your EDV, your end diastolic volume, is the amount of blood in the ventricle before contraction occurs, but once those valves have all closed. So, maybe my definition there is not awesome because valves are not closing until contraction is starting, but the end diastolic, meaning you've had your passive flow and then you've had your atrial contraction into the ventricle. So I should really say before ejection occurs, because we're at the end of the relaxation for the ventricle, we're starting to get into that contraction, right? Does that make sense? Okay, and then the end systolic volume is the amount of blood that's left over in the ventricle after contraction has occurred. So remember the amount of fluid that we had left over in our sponge in that other analogy. Okay, the end diastolic volume, the amount of blood that makes its way into that ventricle, is affected by both filling time and also venous return. Venous return is, of course, talking about how much blood returns to the heart from the venous system. Now, filling time is directly related to heart rate. So we talked about you have 70% of your blood flowing into the ventricle passively, and then the remaining 30% is pushed in. So the slower your heart rate, the more time you have for blood to passively move into the ventricle. If you increase your heart rate, you're not giving very much time for that ventricle to fill. So a high heart rate is a low fill time, which is going to give you a low EDV. So high heart rate, rapid heart rate, low filling time, low EDV. So you want to slow down your heart rate so you can increase your filling time, so you can increase your EDV. The venous return is dependent on several factors. Venous return is talking about how much blood makes its way back into the heart. Now, one of the things that we see venous return influencing is what's called preload. Preload is the stretch of the ventricle. So we've already seen that the more blood you have coming into the atria, the faster your depolarization is of the SA node. Here in the ventricle, we see the more blood you have flowing into the ventricle, the more preload you have, meaning the more contractility you have. So as you stretch that muscle cell, you get more force generated with your contraction. So you get that stretch of your cardiac muscle cells by filling it up. So there's this direct relationship. It's called the Frank-Starling principle, where the more blood you have coming into the heart, the more blood you have pumping out. And this makes sense again in terms of if you're physically active, you have more blood moving into the heart, and you've also increased your demand for that blood through the body. So when you increase your activity, you're increasing your venous return, that's increasing your preload, that's increasing your contractility, the force that you can generate from your heart, so the more blood you have pumping out. When we're looking at our ESV, we're looking at the amount of blood that's left over. So there are several factors affecting this. You have the preload again, you have ventricular contractility, and you have afterload. Preload we've already talked about, and we've already seen the more blood you have coming in, the more blood you can force out. Preload is affecting contractility, but also we see other factors affecting the ventricular contractility. So the more calcium ion you have moving into the cell, the more contractility you have, the lower your ESV is. So again, contractility is talking about the amount of force that's generated, how effective is that squeeze. The more contractility, the more squeeze you have, the more blood is leaving the heart, the lower ESV, the lower amount of blood you have left over. There are hormones and nervous system signals that can influence your contractility. So epinephrine, we've already said, will increase your contractility. It's doing that by directly triggering more calcium to move into the cell. Epinephrine, norepinephrine, thyroxines, and glucagon will all increase your contractility. Acetylcholine, which we know is released from the parasympathetic division, is going to actually decrease your calcium influx, so it's going to decrease your contractility. That's okay though, because parasympathetic is coordinating your rest and digest, it's slowing down your heart rate, so you're releasing acetylcholine in times of rest. You don't have as much demand for that blood to be pumping through the body, so it's okay to slow that down. Afterload is different from preload, obviously. Afterload is basically talking about the amount of tension required to push open those semilunar valves and get that blood really moving through that systemic circuit. So if you have a lot of peripheral blood flow restrictions, it's going to be harder to get that blood actually out of the ventricle, through the aorta, and out to the body. So if you have like roadblocks along the way in your arterial system, then it's going to be harder to get that blood or get that traffic moving through that aorta. So the afterload is talking about, well, how much resistance is there to the flow of blood in the arterial system? If you have a lot of resistance, then your afterload is high, it's harder to get the blood out, and you're going to have a high ESV. If your afterload is small, if there's not a lot of resistance, you're going to have an easier time pumping your blood out of the heart, and your ESV then would be low. So you have a direct relationship. High afterload, high ESV. Low afterload, low ESV. Okay, so let's try to start putting stuff together. To have your maximum amount of blood moving out of the heart, you want a high cardiac output. So that means you need to have a high EDV, you need to get a lot of blood into that ventricle, and then you need to get as much of that blood out of the ventricle as possible to the body. So that means you need a low ESV. In order to have a high EDV, you need a slow heart rate. A slow heart rate is going to increase your filling time, so that's going to increase your EDV. So you want a low heart rate, a high filling time. The more blood flow you have into the ventricle, the more preload you have, the more contractility you have. So the high EDV gives you a high preload, which gives you a high contractility, helping you to force that blood out. So that's going to correspond to a low ESV. So in order to get a good cardiac output, you want a high preload, you want high contractility giving you a low ESV. In order to get that high preload, you need that slow heart rate to increase your filling time. You also need to recruit a lot of blood from your veins, so you need a good venous return. So again, one way to do that is just to be physically active, because remember, the vein itself is not really pushing the blood back to the heart, but it's gravity if you're above the heart, and then it's the skeletal muscle contraction, the surrounding skeletal muscle contraction for everything below the heart. So when you're physically active, you're increasing your venous return. That's going to get more blood into the heart. That's increasing your preload, and all of those other factors. So there's lots of things that are connecting together. It's not things in isolation here. Okay, so we've already said if you have a high preload, the more you have in, the more you have out. So high preload corresponds to low ESV, so that's good. A high contractility, a generation of a lot of force, is going to give you that low ESV. So we can do that by having a high preload. We can also do that with hormones, so epinephrine, norepinephrine, glucagon, and T3. And then you want to have a lot of control over that peripheral resistance, so your afterload is really low. Remember, if you have a low afterload, you have a low ESV, so that means you're effectively getting the blood out to the body. So in order to have a high cardiac output, you want a low heart rate. You want a high filling time. You want a high preload. So you get that by having a high filling time and also by increasing your venous return. You want high contractility, so you can generate a lot of force to push that blood out. You get a high contractility because of a high preload, more in, more out, but also because of those hormones, epinephrine, norepinephrine, glucagon, and T3. And then you want a low afterload, so you want a low peripheral resistance. So let's look at some factors that affect peripheral resistance next. This information is also coming out of a small piece of chapter 1. So what you can see that I'm doing here in the cardiovascular chapter is I'm combining information from chapters 20 and 21. Peripheral resistance is talking about the ability of the blood to move through your arteries. And we can describe that as vascular resistance also. So peripheral resistance is talking about your vascular resistance. How easy or hard is it to get the blood moving through the blood vessel? So there are several things that can create resistance. So as you increase the length of your vessel, you're increasing the resistance, the difficulty to get material through. Think about your ability to blow through a straw, blow a wad of paper through a straw, versus your ability to blow a wad of paper through a hose. The longer that hose is, the harder it is to get your breath to actually force that piece of paper all the way through. It's the same kind of idea. Now, obviously, this is not something that's homeostatically regulated. This has to do with the size of your body, but we can see this playing a role when your body is growing and you're increasing in size. A lot of times with growth spurts, you have this rapid increase in the length of the body, which can correspond to some changes in blood pressure. Now, the rest of these are things that are dynamic, that are changing in the adult, and that are also homeostatically regulated. So we have blood viscosity. The term viscosity is talking about thickness of your blood. So honey is very viscous. Water, not so much. Water flows much easier than honey does. So the thicker your blood is, the higher your blood viscosity, the more resistance you would have, the more difficulty you would have moving that through. So this is one of the issues with diabetes. And diabetes mellitus, you have increased sugar in your blood. It's making it thicker. It's increasing your resistance. It's not moving through your blood vessels in the way that it should. And so it's creating lots of problems with your peripheral tissues and lots of damage occurring to the cardiovascular system itself. So a lot of those problems that show up with diabetes is related to this idea here. Increased turbulence. So we live in an area with lots of creeks and streams and rivers, and they're all very rocky. So you already know if you have a big boulder in the middle of the flow of water, it's going to create a little pool, and it's going to create a rapid, and the water's going to flow around that. The same thing is happening in your blood vessels. So if you have plaques or other obstacles in the way of the flow of blood, that's turbulence, that's increasing resistance. But also as the diameter of our blood vessels change, this is something that is dynamic, that's happening. If you go from a big diameter all of a sudden to a small diameter, then you're going to create a little bit of backflow or turbulence right there when that change happens. So that can increase resistance. So we will see that happening. And then again, the vessel diameter itself, obviously, if you have a big diameter, you have less resistance. So I have that one backwards, right? You have an increased diameter. You have it, well, let's do this. Decreased resistance. So a bigger opening is easier for materials to move through versus a small opening. So that is something that has the, it's not a direct relationship, right? It's the opposite. And then what we see is that, oh goodness, let's edit here again. When you increase your afterload, you're increasing your ESV, meaning if you have a lot of resistance out in the body, you're going to have a hard time pushing the blood out of the heart out to the body. So you're going to reduce your cardiac output. So some of these things you already know are leading to cardiovascular disease or damage have to do with this fact that you're having a hard time getting that blood pushed through from the heart as a result of these different resistances. So that heart tissue, the cardiac muscle, might have to work harder to get that blood pumped out because of these types of resistances. Okay, and that is it for now.